Thank you, Ellie. And good morning, everyone. It's a pleasure to have you with us for NATO's 37th, yes, 37th annual conference, Putting Healthcare Data to Work. I'm Norm Thurston, NATO's Executive Director, and it's my privilege to kick off today's sessions. We are excited to recognize the sponsors that make this conference possible. We hope you will support them by visiting their booths and reaching out to thank them for their sponsorship. We would also like to recognize our collaborating partners, Milliman MedInsight and Verado, as well as our featured and contributing partners. Their engagement throughout the year is key to our success as an organization. NATO's all-volunteer board puts in a lot of work to support our organization. We hope you appreciate their efforts on your behalf. This year's Program Planning Committee was led by Craig Schneider and has done a fantastic job of assembling the best content on the most relevant topics. Thank you all for the many hours you have put in to make this happen. Now, for some of you, this is the first time using the WebEx Events platform, formerly called Socio, and the same one we used last year, actually. But here are a few pro tips to enhance your conference experience. First, there's a link to the full conference program on the left of your screen that shows you the session times, titles, and speakers all in one document. As you now know, the agenda feature is your pathway to participating in those sessions. We hope that everyone will play our token hunt game. Simply type in keywords and tokens as they show up on the screen to earn chances for prize drawings. Part of the challenge of being here virtually is learning how to network. We are facilitating that through special networking sessions each day where you can meet experts and health data insiders. You won't want to miss those, so make sure to put them on your calendar. You should also visit the sponsor booths and make connections with them, reach out to them, ask them questions. You can use the attendees list on the left to find and connect with each other. Again, an important part of this conference is the networking. And then there's the wall. The wall is your place. Please fill it up. Put in comments, thoughts. Keep track of that. Follow with other people. Now, as much fun as this is going to be, we are in fact looking forward to seeing you all in person next summer in Boston. So mark your calendar and save these dates, August 14th to 16th, 2023. We will see you there. And now let me introduce NATO's board chair, Kenley Harrington from the Maine Health Data Organization, who will give today's opening remarks. Kenley.
On behalf of the Board of Directors for the National Association of Health Data Organizations, I would like to welcome you to the organization's 37th annual conference. This is NATO's third annual conference held virtually, and I'm pleased to report that over 400 participants have registered for this meeting, representing over 100 healthcare data organizations from all over the country. We also have 20 meeting sponsors, and because of their generous support, this event is possible. The theme of this year's conference, Putting Healthcare Data to Work, builds off of last year's theme, Rising to the Challenge, Connecting Data with Policy. This year, our speakers will focus on topics that many of us are grappling with as we manage our current data assets and prepare for the future needs of healthcare data. We will hear presentations and discussions on topics like health equity and disparities, data governance, efforts to ease the sharing of data linkages, the impacts of COVID-19 on data, and we'll hear national and state trends and priorities discussion. Many of us are using our data assets, both claims data and hospital discharge data, to produce analyses and information that informs our policymakers both locally and nationally, as well as other key stakeholders. Analyses include the ongoing impact of the COVID-19 pandemic, the opioid crisis, the rising cost of prescription drugs, the state's total healthcare spending, the transparency of healthcare costs, and issues regarding health equity and disparities. Now more than ever, we know the value and importance of a comprehensive, credible healthcare data infrastructure that supports putting data to work, and this starts with a data governance plan. We know that we need to build secure and nimble data systems so that as the environment changes, for example, alternative payment models replacing fee-for-service models, and as research needs change, our data structures and governance plans continue to be relevant, complete, and accurate. We also know that linking our data assets to other data sets has the potential to significantly enhance the ways in which our data can be used. A quick example, in my home state of Maine, our legislature and governor passed a law over a year ago that requires the Maine CDC to send its data from the Cancer Registry and Vital Statistics to the Maine Health Data Organization, and for the MHDO to then link these data with our all-payer claims data and hospital discharge data sets. Linkages between MHDO's data sets, the Cancer Registry, and Vital Statistics will provide a more complete data set that will allow researchers to identify when gaps in care are occurring during cancer prevention, diagnosis, treatment, and mortality. MHDO's linked dataset will support the Maine Cancer Foundation's development of the state's first comprehensive cancer blueprint, an interactive, data-driven tool designed to increase knowledge and awareness of issues related to cancer, expand access to care, and support lifestyle changes to reduce cancer risks. Over the next 3 days, we will hear from our peers and experts on how they're putting healthcare data to use and what some of the challenges and opportunities are as we move forward. We hope that the speakers and sessions this year provide you with insight and information that you can take back and apply to your work. I also want to encourage you to take advantage of networking virtually with your peers and our sponsors, as it's so important as we work to strengthen our data community. For those presenting, your experience and knowledge is invaluable. Thank you for taking time to share it with all of us. I also want to thank the members of the Program Planning Committee and the NADO and APCD Council staff for your ongoing support, guidance, and expertise in planning and organizing this year's annual meeting. Each year, I'm amazed at the amount of teamwork involved in pulling together this event. At times, the challenges may seem overwhelming as most of us continue to be asked to do more with less, but it's also one of the most exciting times to be working in this field. Now more than ever, we need to stay connected and share best practices and experiences with one another, which is sometimes easier said than done. But when you make these connections, they really do make a difference, as I've learned firsthand over the last 10 years. NADO will continue to support uniform data standards and practices, keep us informed on matters that impact our work, help us leverage our shared goals, and foster networking and collaboration. With the end of my 6-year service on the NADO Board of Directors approaching, I'd like to take this opportunity to thank the board for their trust in my leadership as we together navigated through some challenging times. I'd also like to thank Norm and Joe and the NADO and APCD Council staff for their support over the years. I look forward to NADO's continued success and to the new board leadership who will continue to help shape the direction and sustainability of the organization. Again, on behalf of the NADO Board of Directors, thank you all for participating in NADO's 37th annual meeting. Now let's go have some fun.
Thank you, Karen Lee. Those were wonderful remarks, and we appreciate them very much. Now let's start with our opening plenary session. Today's opening plenary session is sponsored by Verado, and we have with us today Sarah Herdman from Verado, who will give some introductory remarks. Sarah?
Hello, everybody, and welcome. On behalf of Verado, I'm glad to be here this week with all of you and excited to introduce today's opening plenary session. At Verado, we're big believers in the power of complete and trusted data to derive better decision-making and workflows in healthcare and government. We help our customers assemble and share true 360-degree views of patients and providers from fragmented data in siloed systems. We'd love to see you later today in our sponsor booth during the afternoon breaks. And now, without further ado, I'd like to introduce our first session of the day, Efforts to Ease Data Sharing, Policies and Program Design.
Thank you, Sarah. Today's plenary session is organized and will be moderated by Kenley Money from the Arkansas Center for Health Information. Let's go ahead and bring Kenley on stage. Hey, Kenley, how are you?
I'm well. Thank you. Enter stage left.
Yay. All right, let's get this going. Yay, we're excited. Take it away.
All right. My name is Kenley Money. I am with the Arkansas Center for Health Improvement and the director of the Arkansas All-Payer Claims Database as part of the Arkansas Healthcare Transparency Initiative. Lots of words. I have the privilege of serving as your moderator today for the opening plenary session of this year's virtual NADO conference, Efforts to Ease the Sharing of Data, Policies, and Program Design. Much like last year, there will be 3 sections and there will be a video presentation. After each presentation, I will speak. I will have a few questions and discourse with the speaker of that presentation. And at the end, there will be opportunities for everyone to ask questions. Put your questions in the chat, even throughout the presentation, and Charles will collect them and we can ask as time allows, and hopefully time will allow. Our first speaker, Kristin Paulson, the Chief Operating Officer and General Counsel for the Center for Improving Value in Healthcare, CIVHC, in Colorado. Kristin's presentation is entitled Attempts to Overcome ERISA Submission Challenges, something that we all have. So Norm and Charles, I'll turn it over to you to show the presentation.
Thank you. Kristin.
Hello, everyone. My name is Kristin Paulson. I'm the Chief Operating Officer and General Counsel for the Center for Improving Value in Healthcare. We are the administrator of the Colorado All-Payer Claims Database, and I'm here to talk to you about our attempts to overcome some of the ERISA plan submission challenges in our APCD. So CIVHC is a nonprofit, independent, objective organization. We are not a government agency, and we administer the APCD on behalf of the state of Colorado. Our mission is to empower individuals, communities, and organizations through support services and healthcare information to advance the triple aim. To do this, we serve a wide variety of stakeholders across healthcare, including clinicians, employers, researchers, government plans, and of course, everything we do is always centered on the consumer. So I wanted to start today with just a high-level overview of what ERISA actually is. So this is the Employment Retirement Income Security Act of 1974, and it's a tax and labor law that establishes minimum standards for pension plans and employee benefits in private industry. This was created as a result of a pension that actually lost all of its value. So pensioners only received about 15% of what they were supposed to, and there was very little recourse for them. So what ERISA does is it protects the interests of the employees through these benefit plans and the beneficiaries thereof by requiring financial disclosure and other critical plan information to the beneficiaries. It establishes standards of conduct for the plan fiduciaries, and it also provides access to the court system for remedies and any kind of other action that may need to be taken. And this law has actually been very broadly expanded over time to apply to a number of different areas, not just this strict benefit plan space. So I'm sure many of you are familiar with Gobey v. Liberty Mutual. This was a Supreme Court case in 2016. Vermont at that point in time was mandating submissions to the Vermont APCD from all active insurers in the state. Liberty Mutual had just over 100 employees within the state, and through a couple interim steps, ended up suing the state of Vermont or suing the APCD over the burden created by having to submit a unique set of data to every single state across the country, claiming that ERISA preempted the state law and would not allow them to submit. So ERISA does preempt state law. Anytime there is a law that is dependent on the ERISA plan, or when the law interferes with a nationally uniform plan administration. And this was the key to the finding of this case. The Supreme Court did find that the law interfered with nationally uniform plan administration. It created a burden on the employer, on Liberty Mutual, and was therefore preempted only for those employers who self-funded their plans and were subject to ERISA. At this point in time, also the Department of Labor did suggest that the creation of a common data submission structure would help get around the problem. And this is actually what led to the work that Renato has been involved with for years around the common data layout and creating a common basis for data submission across the country. So what is this impact of the lack of ERISA self-funded plans? So without these individuals, we're missing a key piece of the healthcare landscape. More and more employers are switching to a self-insured plan as opposed to fully insured. You can see in that graph, the blue bar is decreasing over the years as individuals switch from a fully insured plan to a self-insured plan. And then, excuse me, and that does limit our ability to evaluate healthcare costs, utilization, quality, and access. So we are missing an increasing number of individuals year over year. For our best guesses, we're looking at about 1 million Coloradans that are missing from the APCD. So we've been working for several years on voluntary submission from these plans. We've worked directly with purchasing alliances here in the state, Colorado Business Group on Health, the Denver Chamber of Commerce, and others to encourage voluntary submission. In collaboration with the state of Colorado, we also developed a suite of standard reports for employers and that would allow them to actually have more leverage in negotiations with their providers. We've also provided a legal opinion on the ability to voluntarily submit and then provided step-by-step resources that are available on our website, including a voluntary opt-in form to start submitting to the APCD, a business associate agreement draft for a TPA or ASO, and then also a data sharing agreement. So some of the challenges that employers have when trying to submit data is coming from the TPAs and ASOs. So we've encountered a number of employers that want to submit, but are being told they're not able to voluntarily submit. And some of those barriers include financial barriers, where the TPAs may be implementing a PMPM cost for submission to the APCD, sometimes up to $3 to $5 PMPM. There are contractual prohibitions against submission to the APCDs. So the contracts between the employer and the TPA are actually prohibiting submission to the APCDs. And then there is also some concern around the status of APCDs as a covered entity and HIPAA privacy concerns, which is interesting because it's the same kind of data that they're already submitting for the fully insured plans, but this is where folks are finding challenges. So what did we do? So our goal was to level the playing field for those ERISA covered entities and to give them a chance to easily choose to voluntarily submit to the APCD. So Utah actually did include some language to this effect in their enabling statutes. And so we wanted to kind of follow along and use Utah's lead and see where we could get in Colorado. So in our data submission guide, volume 13, which was last year, we tried to clarify the language around the requirement to submit if you were a non-ERISA self-funded plan. We wanted to require that payers that were already submitting data to the APCD, so they already had the data submission infrastructure built, had to allow ERISA self-funded employers to voluntarily opt in to APCD submissions at no additional cost, and also required that payers annually file some administrative information related to the data collection effort. And unsurprisingly, the language was met with significant resistance from payers. Payers were very, very concerned about whether this was actually preempted by ERISA itself, that this may have created a constraint on contracting, which is prohibited under ERISA. It's interesting because this isn't actually a constraint on contracting, it's a mandatory expansion of contracting. So mandatorily expanding what was being offered to ERISA plans so that it was the same as other plans. And so the ERISA question is still unknown. But the thing that ended up really throwing a wrench into things and preventing Colorado from putting this in place was that we don't actually have any established regulatory enforcement mechanism over the TPAs and ASOs. There is no authority, not the Division of Insurance, not the Department of Regulatory Agencies, not Medicaid. There's no one in Colorado that actually has regulatory authority over these entities to make them do anything. So that's kind of where we are right now. We're constantly looking for different ways we might be able to approach the ERISA issue and might be able to make some progress. We're hoping that perhaps our attempts, our language modifications might help others out there trying to do the same thing. And I'm happy to take questions if anyone has one at this time.
Thank you, Kristin. Thank you. I read with great interest any attempt to get ERISA data. So at this point, I have a couple of questions, and I will remind the audience that they can put questions in the chat, and we'll get to them later as time allows. So ultimately, how many ERISA covered employers were there, and did any even voluntarily submit? And then how many members do you think you're still missing?
So those are great questions. The answer to the number of ERISA employers, we actually don't know. Because of Colorado's sort of regulatory structure around TPAs and ASOs, we don't have any insight into how many employers or how many lives they actually cover. So we can guess, but we don't actually know for sure how many folks there we're missing. We can do some guesses. We currently estimate that we are missing about a little more than half of the ERISA covered lives. We think it's around 1 million folks total, but again, we don't really know for sure. We have had some folks who are voluntarily submitting. We do have voluntary submitters, various organizations who've come in and have seen the value. We've built a number of reports for employers. And so we do have employers that want to take advantage of those reports and have started voluntarily submitting. We do know, again, that people are hitting barriers and they're really having a tough time being able to voluntarily submit, which is what this is trying to get over. I do want to quickly just, Betty put in the chat here. So non-ERISA self-funded plans would be plans like a municipal health plan or a school district plan. So they would be funded, publicly funded, excuse me, publicly funded individuals who are, or organizations who are self-funding their insurance plan. Yes, sorry.
This was modeled, your work's modeled after Utah. Do you know how successful Utah has been?
They've had some success. We did talk to some folks at Utah. They've been doing this from the beginning. This was written into their original APCD legislation. Some of the challenges that they had were, enforcing that the payers were actually offering this as an outreach, a proactive offering of submission, and then also the concerns around how the payers were describing the benefits or lack thereof of submitting to an APCD. And so that was one of the challenges they had. The benefit that we were hoping to have on our side was the fact that our state was very enthusiastic about this and was going to be doing some state-initiated rollout to do enforcement around these. But unfortunately, as I said in the presentation, it did not move.
Yeah. So what about this project surprised you?
I think the thing that originally surprised me were the barriers really that were thrown up by the payers. And I apologize to all the payer friends in the audience, but it was very challenging, especially when we had payers that already had the infrastructure in place to be submitting, because they had to submit their fully insured and their non-ERISA self-funded, and then putting a cost barrier on the employers was very surprising. But I think that was really the big one. I mean, and then obviously finding out after we'd put in many hours of work on this, that we lacked a regulatory mechanism to even move forward, and that it had somehow managed to avoid the attention of all of us. We had various state departments involved in this with the AG's office, and so that was the other sort of unpleasant surprise at the end of all that work.
My last question is what would you have done differently? You may have already answered that just a bit with the last two.
I would have made sure we had the regulatory authority to do this at the beginning. The other piece that we ran into was concerns about that this was a constraint on contracting. Utah did not get that same pushback when they put this through, but we got significant pushback that this was a constraint on contracting under ERISA. What this actually was is a mandatory expansion of benefits, and that is a kind of an unsettled space in ERISA law. And so that was the other piece that I think I would make sure that folks went into a little bit before tackling this, just because it's not necessarily 100% settled what ERISA says about the ability to expand benefit offerings to covered entities, ERISA covered entities.
Yeah. Well, thank you. Thank you. That concludes this section. Again, if you have a question, put it in the chat. We'll have time at the end. Kristin, thank you. Wonderful subject. And
Thanks,
let's
Kenley.
move to our second presentation.
Great.
All right. With Kristin still. So our second presentation, Charles, I'm faster than he, sorry. Our second presentation, Finding a Way Forward, Creating Strong Legal Frameworks for Data Integration. This is presented by Amy Hawn Nelson and Deja Kemp from ACIP, Actionable Intelligence for Social Policy. So without any further ado, let's watch their presentation.
Greetings. Today we are here to talk about a new report that we have just released that we are very excited about called Finding a Way Forward, Creating Strong Legal Frameworks for Data Integration. I'm Amy Hawn Nelson, and I'm joined today by my colleague, Deja Kemp. AISP is a small initiative situated at the University of Pennsylvania, and our role is to help state governments collaborate and responsibly use data to improve lives. It can be somewhat helpful to think through what we are and what we're not. We do not hold data. We are mainly connectors, singularly focused on ethical data use for policy change. And our core work is to run a national network of sites across the country who are integrated data systems. So what do we mean by integrated data systems? Most importantly, we are talking about people, not technology. We are talking about cross-sector data sharing that is routine and ongoing. It is not a one thing kind of project. And these are efforts that serve a public utility. So research is involved, but not research for research's sake. It must be disseminated widely and used by government agencies. Our core work is to draw upon this peer network to learn from each other. We produce guidance and standards. We do quite a bit of training and consulting, a lot of advocacy, and then actionable research. Most importantly, we want you to remember that data sharing is as relational as it is technical, and that we don't just need to integrate data, but we need to integrate people.
Perfect. Thank you, Amy. And so as my colleague mentioned, we are here to introduce a very new resource. This new report builds upon and expands upon our 2017 publication in important ways. Most importantly, our understanding and guidance around creating strong legal frameworks for data integration has grown. And so this report reflects that. Next slide, please. So this new report builds upon our quality framework for IDS, and we see this as an important tool for understanding the key components of shared data infrastructure. While no two integrated data systems are identical, there are many learnings from looking at the experiences of different approaches. And to reiterate, this content is not theoretical, but it is based upon site-based learnings and decades of work in this field. This is all very, very pretty on our website, so I would also recommend that you check it out. Next slide. So this report is organized around 4 overarching questions to consider. The first is it legal, which we see as the lowest bar? The second is it ethical? The third, is it a good idea? And the fourth is, how do we know who decides? Next slide. So regarding the basic question of whether this is legal, this is largely going to depend on the type of data in use. And we discuss in the report what we view as the 5 bases of legal authority for integrated data, all of which will be informed by the access of data. So whether it's open, restricted, or unavailable.
So it's important to think about this report as being a resource. So each selection frames out key concepts and then provides lots of practice activities to allow you to think through the content of the section. There are a lot of questions, and it's really meant for you to kind of, explore your way through it. One of our activities that we think a lot about are these questions of, is it ethical, right? Our second big question. And one of the ways we like to think about this is the concept of social license. So does your data integration effort have, license to do this from the community that it is serving? One way to think about another way to think about this is through the concept of risk versus benefit and being very explicit about conversations to weigh this. Another idea that we think a lot about is around data availability, resources, and action. And that really answers the question of like, is this a good idea? So it is legal, it is ethical, we've decided, but is it a good idea, right? And then the next question is really around who decides these things. So is it legal? Is it ethical? Is it a good idea? And who decides, right? And this is where my favorite answer comes in. My answer to most things is data governance. So data governance, we think of as the people, policies, and procedures that support how data are managed, used, and protected. So we talk a lot about data governance in this report. A key component of data governance is thinking through different roles of data users. And so we like to think in three big buckets here. So data owner, data steward, data custodian, and we walk through these as well.
All right. So the next thing that we discuss in the report is our recommended legal approach to structuring legal agreements. And so we recommend 3 agreements: an MOU or a memorandum of understanding, sometimes called an enterprise memorandum of understanding, a data sharing agreement, and a data use license. So briefly, an MOU outlines the purpose and governance process. It's the main document that outlines the rules of the road. It says, if we decide to share, this is how it will happen. Importantly, it doesn't obligate a party to share. The next agreement is a DSA. This names the data assets, how it's transferred, stored, and shared. And finally, the DUL outlines the responsibilities of the data recipient. And it works like a traditional license in that it's revocable, non-transferable, time-bound, and it doesn't bestow any other property right. So graphically, this is how we envision this would work. Agencies would sign on to an MOU establishing the governance and process. They would then create a DSA that outlines the data holdings, what they're agreeing to share, the rules surrounding that sharing. And then finally, there's a DUL where usually a third party like a researcher or analyst requests data that they would then issue the license. Sometimes there might be cases for a DUL between the agencies. And the most important thing about this is, while not all 3 are required, this process allows for efficiency, uniformity, and constitutional continuity.
So this is a slide that kind of describes one site. What we heard loud and clear from everyone is that people need examples. So through this report, we were able to give 8 site examples. These are actual examples from our network. Whenever possible, we have hyperlinked things such as, legal documents, governance documents, and such. So this is we've heard is a very helpful part of the tool, and we encourage you to go straight there.
The other part that this report covers are the main federal and state laws implicated by data integration, which is also a helpful resource. And then the next slide, what's new to this report is a discussion of tribal data sovereignty, namely the rights of tribes to own and own, collect, and use its own data. Tribes typically have that authority to administer the collection and use of their data. Tribes can enter into data sharing agreements with states, but it's also important to note that tribes are subject to the plenary power of the United States. So for example, if a tribal health department provides HIPAA-covered services, they have to comply with HIPAA. So again, this report goes more into this, and we would encourage you to take a look at it. The last thing and what I think are the treasure trove, the meat of this report, are the appendices. We list some federal law and policies, some sample executive orders. So we absolutely recommend that you check it out and think that it will be a really helpful practical tool for practitioners. Perfect.
All right. Thank you, everyone. Here's our contact information. We encourage you to reach out to us, and we look forward to interacting with you. Thank you.
All right. Thank you so much, Amy and Deja. I have some questions. Let's begin to interact here. Let me see here. What's the best one to start with? Were you able to collect agreement examples or templates and establish some recommended best practices from all the states that you worked with?
Yeah, so actually, the templates that are located in the appendices were created from other existing agreements and templates that reflect best practices for data sharing and memorializing the legal requirements. So we definitely recommend that people check out the sample templates located in the appendices.
Okay. What were some of the key differences in agreements across the states? Did anything stand out that was included or omitted?
Yeah, for sure. We think a lot about this. Running a national network, we often see differences, and those differences are meaningful, right? They're not arbitrary. So in the report, we featured 12 data integration efforts from across the United States. And we very carefully describe their geography, their management model, and their purpose for integration. So, and we find, and the reason why we categorize sites that way, and that graphic that you saw on our slide deck a minute ago, is because the agreements vary for those reasons. So a state data effort is going to be structured slightly different than a local one. And a data effort that focuses on operational use and case management is going to be structured significantly different than a site that is just being used for, research evaluation purposes. So there's also a place on where the management is, the kind of management model, is it situated in an executive office? Is it in an agency, especially a health and human service agency? Is it some kind of university public partnership? Or we do see a few of these that are based in nonprofits. So because of those, different places have different authority. And so therefore the legal framework is going to be very different.
Mm-hmm. Interesting. While this topic focused on legalities, what do you think is the next most important part of the framework on which to focus? Governance, technical, capacity, impact?
Yeah, so we have strong feelings about this. We have a whole thing that we call our quality framework, where we think through like these 5 pillars, right? So 5 pillars are governance, legal, technical, capacity, impact. And they are interlocking. We always recommend starting with governance and then operationalizing your governance within your legal framework. Mm-hmm. So please don't start with the technical. You will mess it up and it will not go well. And you will spend a lot of money that you don't need to spend, is our big high level overview of that. So start with governance, start with the people who's going to make decisions. How are they going to make those decisions? Operationalize it, and then figure out the tech. We found the tech is very solvable versus the legal gets quite hairy.
What surprised you most?
I think, and maybe this will also go to the next question about what we would have done differently.
Yeah, well, let's ask that at the same time.
Well, yeah. So I think what surprised us and what we would have done differently was the lack of guidance there was on consent. You'll notice that section in the report is pretty short, and that's really because a lot of our discussion was limited by the resources that are out there. We weren't finding a lot of resources that spoke to the complexity of the issues surrounding consent. So in the future, as our understanding evolves around what ethical consent looks like, we hope that our guidance would reflect that. Another thing that we would have done differently, or something that surprised us when it was brought to our attention, is that when we first started to write this report, we actually had no discussions of tribes. And so, when that was brought to our attention, we realized, wow, that's really a gap in our understanding. So one thing that we would do differently, and we're excited about, is just expanding our knowledge of tribal jurisprudence, to be able to continue to write and offer those resources.
Mm-hmm. Do any of your agreement examples or templates have consent language or direction or anything like that?
There's some, so we do hyperlink some consent resources
Okay.
in the report.
All right.
And
Well,
and
go ahead.
I'll say real quick, one of the reasons we don't include it is because we're very committed. We are applied researchers, so
Mhm.
we don't talk about it unless we've seen it. And
Certainly.
so if you see something that AISP publishes, it means we have seen it work. We have seen it effectively rolled out in this way. And we don't talk a lot about consent because frankly, we don't have a lot of great use cases for it. Where it is in place really clearly are places where there's already clear legal authority and you have to have it. But we just, it's not quite there. The technology isn't quite there. And then the legal framework isn't quite there. And it's a little bit, it's totally different based across every site. And we haven't seen it. We haven't seen exemplars or best practices around it yet.
Interesting. All right. Well, thank you. Thank you so much. Let's let you exit stage right, and we will go on to our last speaker. I think that went left. All right. I am pleased to present the next presentation, or open it up. It's called Hospital Discharge Data and Interstate Data Exchange, presented by Shalini Parekh and Generosa Kakoti, my apologies, from the Tennessee Department of Health. Let's introduce them, let them come to the stage.
Hello, we're from the Tennessee Department of Health, and we're here to talk about our hospital discharge data system and a new program we created called the Interstate Data Exchange Program. Speaking today are me, Shalini Parekh, Assistant Commissioner for the Division of Population Health Assessment, and Dr. Generosa Kakoti, Director of the Office of Healthcare Statistics. The Tennessee Department of Health is located in Nashville, Tennessee, and it houses our hospital discharge data system, which receives billing data from 127 hospitals located across the state of Tennessee. Now, the purpose of our Interstate Data Exchange Program was to establish a reciprocal data exchange project that receives hospital discharge data for state residents that receive medical care from other state hospitals. So why was this created? Well, currently, Tennessee hospital discharge data only includes data from other Tennessee hospitals. And because some Tennessee residents obtain their medical care from hospitals in other states, this leads to an inaccurate estimate of disease burden if we're looking at just hospital discharge data. This map shows non-Tennessee resident hospital discharge records by state. And as you can see, states such as Georgia, Mississippi, Kentucky, and Virginia have residents that come across the border to Tennessee to receive their medical care. So there is an exchange of patients that go across borders to go to hospitals in other states. So the solution that was proposed was our Interstate Data Exchange Project, which creates a mutual exchange of patient data of state residents to improve data quality. In order to do so, we established data use agreements with neighboring states to govern the release and use of data. Now, this slide talks a little bit about the benefits of data exchange. I'm going to go through this figure in a clockwise motion, starting with disease surveillance at the top. Receiving more complete data from other states really helps us get a better picture of disease incidence across the state. Economic valuation is another benefit, and it helps us determine the true market share, costs, or advantages of seeking care in another state versus our own. Needs assessment, policy development. More complete data helps to inform policy and practice decisions and enhance the analytical workforce and information structure. Needs assessment. More complete information helps us determine areas of need or intervention, whether they're geographic, racial, or disease specific. Strategic planning helps us decide where in the state new hospitals need to be built in order to meet needs. And then finally, care evaluation would be an example of evaluating readmission rates and determining full course of care for patients with cross-border treatment or hospitalizations. So before we embarked on this project, we decided to get feedback from key health department staff to talk about the benefits of such a program. And focus groups were created, which revealed very strong support for the program, and a discussion about potential utility was large. They talked about specific program gains. For example, for the opioid program, some opioid overdose indicators are based on residency, and data provided from other states will help maintain consistency and provide a more complete picture of overdose effects on Tennessee residents. The COVID pandemic response. During the heart of the pandemic, where hospital beds were in short supply, many Tennessee residents were transferred to other state hospitals in order to receive care. This exchange program will help us follow them as they made that cross-border move. And then finally, geospatial analysis. At this time, a lot of residents that live at the border of Tennessee are often lost, and this will help fill in the gaps so geospatial analysis will be more complete.
So how do we go about setting this data exchange? There's basically two steps: reaching out to neighboring states and having regular internal inter-office meetings to discuss how this exchange would take place. What framework would be used for this exchange? So we have reached out to 15 states. We needed to figure out if there's any interest in exchanging data and whether they'd like to participate with us in this data exchange. We then set out meetings, internal meetings with the states to figure out what agreements need to be put in place and to understand their processes. The states that we met with have shown interest, and we have moved on to creating data use agreements. So this means internally we're required to have regular meetings to iron out all these details. Currently moving forward with an agreement with 2 states, and hopefully in the next few months we'll have an exchange of data. So internally, what did we do? We had basically three different units in the Department of Health working together to try and make this program work. The Division of Population Health Assessment was tasked with the variable analysis and data management, figuring out what data do we need, how are we going to house it, and who's going to be responsible for that data collection and putting it together. The Office of General Counsel is very, very helpful in that they help us iron out the legal issues. What is involved in terms of the state legislation, how we can exchange the data, how we can reuse it, and what is involved in that. And then the Office of Data Governance is important in helping us figure out data security and exchange, who will use the data, how they'll access the data as well. So what are the lessons learned throughout all this process? Basically, engage your stakeholders, understanding legislation, and utilizing your resources. It is important to engage stakeholders during the process, including leadership, legal team, information technology, and users of the data to ensure buy-in, security of the data, and that all state legislation is followed. Understanding legislation is important. Legislation regulating data sharing, which varies from state to state, and what can be exchanged and released is important. In some states, multiple agencies manage the inpatient and outpatient data sets. We also need to understand who can receive the data. What are the HIPAA considerations as far as this data exchange is concerned? You also need to identify what resources do we have available, and it's important to look for outside resources to help you, or we found it important to help us in setting up this data exchange. We worked with NATO, who is very helpful as far as technical assistance in helping us reach out to other states and see who the contacts are. Merging the data. Developing a system to merge data sets that is unique to each exchange and ensuring that end users understand this process was another challenge that we faced. Deriving a common set of variables depends on what individual states collect and may exchange. States can collect different data elements from what we have, and then we have to line them up. initially, what we needed to do is figure out from our own data set, what can we exchange, what we would like to have back in return, and that helps set up the exchange and deciding what variables we would like to have from other states. Otherwise, if we don't take this into consideration, you may end up having a limited data set that its usefulness for multiple purposes may be limited. The significance of this project is that the Tennessee Department of Health will gain a more complete data sets for analysis to achieve the department's vision. In addition, these agreements will help foster interstate partnerships that may lead to a more cooperative and cohesive response in the efforts in the future for an array of public health concerns. In conclusion, a hospital discharge data interstate data exchange program has been successfully embarked upon at the Tennessee Department of Health. We are really excited that we are getting this data from other states, and we would hope that our process would encourage other states to do the same and hopefully exchange, the ones we haven't reached out to, exchange data with us. Thank you.
All right. Thank you so much. That was wonderful. So I have a few questions, and then I will start reviewing the questions that were in the chat. And that doesn't mean that questions can't continue to be added to the chat. So if you think of one. Okay, so to begin, what were some of the state-specific DUA requirements that you've encountered that you had to work through to find consensus?
Yeah, so some of the requirements that we found were that the data is not sent or used by third parties, but the data is only used for public health purposes and research. And then finally, a lot of outlines around confidentiality in the storage of data. So it's really very standard across all the DUAs that we have at the Tennessee Department of Health.
Okay. Were you able to, did any one of them give you more heartburn than another?
It's really been quite a smooth process. Generosa, do you want to give your thoughts on that?
I think we were both, the ones we've worked with, we have the same understanding, so we have the same purpose. So there was no opportunity for heartburn in that instance.
You're lucky. My next question is a bit related. What are some specific legislative differences or challenges that you encounter?
I think as far as legislative is just who can use the data? How do you distribute the data? Can you release data? That's really challenging. So trying to figure out what the different laws are, and that's where our general counsel is really helpful in trying to figure that. But I think also a challenge is trying to figure out who is the right person, or who do we work with? Like, right. Is it this agency? Is it that agency? Who has rights to the data? Who can allow us or facilitate this exchange? And that has been a challenge, just getting the right agency or person.
What did you do? Did you just call the agencies? How did you resolve that?
Emails and phone calls.
Yeah. Are you the right person? So in your presentation, there was a map of the states surrounding Tennessee. What states are you going to reach out to next? Or is it
Actually, we are reaching out to, those are the ones that we have data on their patients, on their residents.
Okay.
And so we're reaching out to them, but also we're reaching as far as Massachusetts or Connecticut. Right. There is no limit to which they would like to work with, because we don't really know where our residents are going. And so we're just trying to get that data. Yeah. Mm-hmm.
I didn't know if you were anticipating, because wherever the specialty clinics are, like in Arizona or Illinois, anyway, to get ahead of it. But okay, so what about this process surprised you?
I think what surprised us perhaps is that some of the caution that we saw from other states that we reached out to. And I don't know if it necessarily surprised us because we do understand it, but we really do encourage the states to partner with us because it's a learning process, but it's actually gone a lot smoother than we thought. And as for one thing that we would consider, we are really proud that we did, is that we included our general counsel and our data governance folks in each one of our meetings with our states, just to make sure that we were aligned with Tennessee law and that we didn't make any promises that would go beyond that. So, yeah, that's my answer.
So there's that term again, governance ahead of time.
Yeah, absolutely.
What would you have done differently?
I don't know that I would identify anything that we would do differently. It's been going so well. I just think we would consistently keep general counsel on board and in data governance just to make sure that, things stay aligned with the way they should.
Okay.
Yeah.
Well, thank you so much. Charles, can we bring everybody on and then I'll read some of the questions in the chat? Charles, our faithful stage manager. There we go. Great. Okay. Kristin, why don't we start with you? Some questions in the chat. Jim Aaron, yes. Do employers have limited leverage over the TPAs with which they contract? Make submitting data to an APCD a requirement in that contract?
Yeah, they do. And we have had some of our employers use their contracts as a mechanism to get their data into the APCD. The problem is that when they do that, what we're hearing is that we've got payers who are tacking on a $3 to $5 PMPM fee for submission to the APCD. And I think for any employer, that's a hefty chunk of change. But especially for our smaller employers who could really benefit from this, that's a lot of money for them to be trying to figure out.
From Paul Smith to Kristin, are you attempting to get regulatory authority through legislation? As of right now, I don't think there's anything moving. The TPAs and ASOs have operated under a very loose regulatory structure in Colorado, and I think there's going to be significant pushback if we try to change that. Right now, they don't have a regulatory agency in our Division of Insurance or Healthcare Policy and Financing, and so that would be the only way forward on the ERISA piece, but that would definitely be a fight, and I haven't necessarily heard that we've got someone pushing to have that fight right now. All right, I'm going to jump to Amy and Deja. I have a couple of questions. You mentioned that you've collected a lot of examples. Yes, and examples are always very, very important and useful. Was there an instance, or can you give an example of an example that actually compelled a decision or action?
Sure. I mean, that's pretty much our whole network. So our network started in 2008. We were asked to find these integrated data systems from across the United States. And so we did a scan and found 8 of them. We now have 36. So we've seen exponential growth in this, largely through people looking around saying, hey, so-and-so's doing it. If they can do it, it's not a federal issue. And if it's allowable in our state context, then how do we do it, right? And the answer is good lawyers and lots of data governance. Because there are lots of ways. That's why the title of our report is Finding a Way Forward, because it's hard, right? And it takes time. I mean, we know that figuring out these MOUs, especially across different agencies, is incredibly challenging. It's challenging internally to a division or department, and then you go across and it's even more. So it takes time and resources, but yeah, I mean, our whole network is an example of that.
Yes. I'm sorry, I'm looking back at a slide to help support the next question that I have.
Yeah.
I'll do, let me go to a different question and then I'll come back to that. So for Generosa and Shalini, Sylvia Hobbs asks, In Tennessee, what would be the administrative advantage of creating separate data use agreements with each surrounding state versus obtaining the data through HCUP single agreement to use data submitted by the states to ACHI?
I think we have more control of what we get, and it aligns to more what we have in our hospital discharge data system, so we can have more data elements. And I think this allows, when we add it to our data, it allows a better integration and analysis of what we have. So basically, while we'd like to have, data, let's say from Georgia, and then try to figure out which one the Tennessee residents and all that, this makes it so much easier for us. We already get that information back, from the other states. And it won't only be our neighboring states, that's the beginning, but we're spreading out to other states like Texas and California, wherever the data may be.
Okay. Now I found my information for my next question. So there were focus groups mentioned from Generosa and Shalini about focus groups revealed strong support for the program and potential utility, and it was very large. And so you listed 3: opioid pandemic, opioid overdose, COVID, and the geospatial. Were there any other subjects that popped up in your focus groups?
Okay. Yeah, I think, for example, our maternal mortality or morbidity group, mothers would have babies out of state, so we get more information on that. So that's one of the additional groups. Also, our injury surveillance group. If a crash happens, for example, in Kentucky, and they brought it to Tennessee, we get that information, the initial information that we're probably missing in our analysis. So there are a number of groups.
Yeah. Okay. Let's see. I'm going to go back to Kristin, and Kevin McCavey asked, how has Civic engaged employer associations and groups to advance self-insured data collection, and what has their response been? Can they be potential allies?
Yes, they can absolutely be potential allies. So we've done extensive work with our employer associations here in Colorado. I think basically from the beginning, we've been engaged with the Denver Metro Chamber of Commerce and the, now I'm blanking on all the different groups we've worked with. So the issues that we're running into are primarily around employers understanding what the benefit can be. So there's a certain level of sophistication generally for employers to really understand what the benefit could be to them. And then the other piece is really, we've got small employers. And so that's when we really would need to get a group of folks together, which we do have in Colorado. Again, we've got a couple of different employer alliances that we work with that have done some really great work in reducing premiums using the APCD data. So that's one of the primary ways actually that we're getting voluntary employer submission is through these alliances. But outside of the alliances, it's very, very hard to create sort of that understanding of the need. And then when you get to some of the larger employers, like Boeing's and things like that, they already have their own internal resources and don't feel like they need to be engaging in an external entity to be able to get additional reporting. And that I think would really help move things forward for us. It would really be nice to be able to get some of those large employers so we can demonstrate some of the benefit. But yeah, it's challenging. I'm actually just got an email in my inbox right now with some frustrations from some of our allies about not being able to really drive that need to get the data in, not being able to identify the value. And so we've got some work to do, but we've been working with them for a number of years and have helped them get some of the gains that they've gotten. I know Peak Health Alliance was celebrating I believe it was a 30 to 40% reduction in premiums for their alliance members through the data that they were able to access and being able to really negotiate strongly with their plans.
Interesting. All right, next question. Claudine asks, are you exchanging, this is of the Tennessee team, are you exchanging confidential data, and how do you get around 42 CFR?
Shalini.
Okay. Yeah, so yes, we are exchanging confidential data. In regarding 42 CFR, this is one of those moments where I really want my lawyer by my side for an answer. But essentially, once data is given over to another state, they are governed by their own laws and their statutes. And so the 42 CFR is just very relevant at the state level of where the data is. So yeah, that is my response for that.
It's fun.
And I can add that we look at what elements that we're comfortable exchanging. So for example, if right now it'll be zip codes and maybe dates and not go into personal identifiable information. But that doesn't mean that going forward, once we're comfortable, that we won't add those elements in. It's just that at the beginning, what are we most comfortable doing, and then work from there.
Okay. Jameen asks of the Tennessee group, are you able to tell us which states you're currently working with? You mentioned you were working with 2 at this time.
Yeah. Sure. Yeah. So we're currently working with North Carolina and Louisiana.
Yeah. Okay.
Yes.
Okay. All right. I'm going to ask the audience, are there any more questions? We have a couple of minutes. Okay. Here's one. Sylvia. Okay. Sylvia asks the Tennessee group, have other states with abortion laws not consistent with yours shown concern about whether the data is used to track women seeking abortions outside the state? How specific is your data use agreement as opposed to a broad public, let me see, broad, Charles, is there more to that question? Well, anyway, let's do the first part about abortion.
As far as not just abortion laws, but abortion records, but any records. For example, in Tennessee, we are concerned about STIs, STDs, and we have laws that's really, really restrictive how that data can be shared. So the intention is not to track the use out of state or an individual, but we could probably find out that there is care that's been taken out of state for different purposes, and that just helps us in our planning issues. But again, even if somebody wanted our data or the data, then that would also be subject to our laws and how we release that data. But currently, most of Tennessee, abortion records are collected differently. And so, yes, while you may find it in our data, but then you'd have to really know a whole lot more to identify that individual. So we're really careful about how we protect that individual as far as this data is concerned.
Okay. All right, everybody, that concludes the opening plenary session of the 37th NATO conference. Thank you very much to all the speakers here. There's the time you can place comments in the chat, network with them offline, and I will turn it back over to Norm.